Edward Roberts. I'm part of the older adults team in public health. I'll be giving this presentation today. If you have any questions, please either put them in the chat where Bradley will take note of them for later, and I will take any questions, or Bradley and I will take any questions at the end of the session. But please do put them in the chat so that they're not forgotten. Otherwise, let's start. So today in the session, this is the way the session is organized. I'm going to have this a bit of an introduction and background, followed by some history, the kind of context within Birmingham and context around older age and LGBT. We'll look at aging and then interactions with healthcare, health and mental health, and then we'll summarize what we've gone through. So this is basically our introduction, and this is what we're trying to demonstrate today, that discrimination due to age and sexual orientation leads to increased loneliness, which compounds mental and physical health, and also interacts with other marginalized identities. So paying attention to that kind of diversity within the LGBT community and within older adults in general. There are many different compounding forms of discrimination. This is not by any means a comprehensive list, but a survey of over 27,000 individuals showed that discrimination based upon ethnicity was probably the highest form of discrimination in this survey, but sexual orientation was the second highest. And then there's age and gender. And the survey on disability here is actually from American data, but I wouldn't expect it to be that different to UK data, and shows that people who are cisgender LGBT suffer more discrimination than people who are not LGBT, and people who are transgender even more again. And these forms of marginalized identities will compound with one another. So we're going to look at a brief bit of history because we're talking about older adults here. So I think it's important to acknowledge some of the experiences people from that generation had and how they may influence their current decision-making processes and views on the world. So this is from the Gay Birmingham History Project. So on the left-hand side, we have the Lesbian and Gay Switchboard that was open in 1975, and I do believe is still open. That's for the West Midlands. The Gay Liberation Front produces this magazine in the middle, Glad Rags. This one's from April 76. And on the right-hand side, we have Women's Disco, which these sort of women's discos were in response to male-dominated, gay venues at the time, because that was the predominant form of kind of gay representation in that era. So there were a lot of female, a lot of women's discos happening. This is 1987, so this demonstrates the impact that HIV and AIDS had, and it kind of demonstrates the kind of political climate that people who were coming of age in this era came of age in. This is really quite harsh. The political figures at the time would say things like calling for gay men to be gassed, to stop the spread of AIDS, and that there was kind of cross-party agreement at that time on these kinds of values or these kinds of opinions. And here we have the Birmingham World Earth Day Memorial Sculpture on the right-hand side to show that this is how the city has remembered these times. And on the left-hand side, there's another kind of poster to show the predominant prevailing attitudes. I think it was in the 1970s around the army and homosexuality. And a reminder that if you were 18 in 1987, you're 54 now, which is not that old. So this is kind of building the idea of what it was like to kind of grow up in the 1980s, which is really important for older adults in this generation who are LGBT plus. And this is a recent history that will have affected many people. So in 1967, sex between two men over 21 in private was decriminalized. Also in 67, the Nightingales, anything in blue is Birmingham specific here. I thought I'd highlight that. Was a community venture that began in Birmingham. In 1973, homosexuality was no longer considered a mental illness. And then in 76, the Birmingham's Gay Community Centre opened for the first time. In 1980, homosexuality was decriminalised in Scotland. Then 1982, it was decriminalised in Northern Ireland. Section 28 ran from, I believe, 1988 to 2003. In 1997, Birmingham's first gay pride march happened, and then also in 97, we had our first official LGBT plus venue, which was Angels. In 2000, the ban on gay and bisexual people serving in the armed forces was lifted, and the age of consent was equalised for same-sex and opposite-sex partners at 16. In 2007, decriminalisation on the basis of sexual orientation was banned. 2010, we had gender reassignment added as a protected characteristic. And in 2014, gay marriage became legal in England, Wales, and Scotland. So that's a brief history that many people in who are older adults now and part of the LGBT community would have lived through some or maybe many of these different events. Okay, so context. This is a diagram and Whitehead model of the main determinants of health. And what I'm trying to demonstrate here is how cultural conditions or cultural values will affect all of these different areas. So housing, healthcare services and interactions with healthcare services, whether people can easily find employment or they become unemployed, their work environment, and also education, whether they are a teacher or whether they are a student. This impacts social and community networks and the quality of those networks that then impacts people as lifestyle factors, and influences lifestyle choices and influences the options that people have based upon the discrimination that they receive from their environment. And social interactions are extremely important to our health. A healthy lifestyle is one which reduces the risk of being seriously ill or dying early, and a social lifestyle is a healthy lifestyle. Social connectivity is linked to health and longevity, and greater social connectivity really does reduce the number of health risks that people suffer from. But obviously, this has to be quality as well as quantity. The good thing about social connectivity is that it promotes it is linked to health promoting behaviors such as more exercise, less smoking or alcohol consumption, sleep quality, and cooperation for treatment of chronic diseases. However, negative social interactions via discrimination can and often do lead to a delay in seeking medical help, and it can result in risky behaviors, so not health promoting behaviors. And they've even been shown to change gene functions to have a really biological impact on people. And this is really important to populations such as LGBT plus that face discrimination within their environment. The LGBT community in Birmingham, um, generally speaking, the LGBT community emphasizes youth, which can lead to isolation and loneliness in older LGBT adults. And in an engagement event that we did last October or November, it was felt that adults in the city in Birmingham felt the city scene was much more for younger people, and they felt kind of that they didn't belong or weren't necessarily welcome within the scene. They struggled to interact with that scene. They also found kind of digital connectivity as a barrier. They don't all have high digital literacy. So the fact that Meetup and other online services to meet people are all online is a barrier, including, for example, Zone magazine, which they mentioned had moved online as well. And they felt that there were no age-specific activities for older people, which was an issue for them. And they would love to have more face-to-face events. And obviously, COVID made things worse as a population as well as many other populations. And they would wanted to see more initiatives to join generations together. So this kind of speaks to that the importance of social connectivity amongst people. So we have Birmingham LGBT working in this area. Obviously, it's a place to meet. They're running a group at the moment called Golden Babs, which is an over 50s group. They're also planning for some later life workshops. I think start next month. But I believe Maria Hughes is in this call. So if you do have any questions, I'm sure Maria will be more than happy to put her email address in the chat, and you can contact her directly. And people wanted more upskilling to organize groups, which we're going to link into in a moment. So this is the Golden Babs flyer showing when it happens every Tuesday, happening at the moment, 10:30 to 1. They're also looking for volunteers. Volunteering is a great way to stay connected with the community. Such a social space organized by the LGBT Centre. This is the workshops that they're running, looking at planning for your fab later life, fitting fitness into your life, finances, a place to call home, and your fab funeral, which is planning around your end of life. So all topics that they're covering, all really important topics that they're going to be working with people who want to attend, and it's all free. So definitely reach out to Maria if you are interested in learning more on this. These start on Tuesday, 12th of March. Then this is to highlight a couple of events that are happening in the city at the moment to show that there are events for queer and LGBT plus people happening in the city. Um, and then this is a Connected Communities project run by the Neighbourhood Network Scheme. In Birmingham, we have a Neighbourhood Network Scheme. There are 10 neighbourhood networks, one for each of the constituencies. We have 10 constituencies as well. Each neighbourhood network is run by different organisations, and they are offering micro grants and training for members of the community to set up groups, so upskilling members of the community. So that links back with what some people in engagement session asked for and thought was important. So you can, again, reach out to Maria Hughes for more information on this. Now, this all links in with problems for older people generally, and then there's also specific problems for people who are LGBT and older, because one compounds with the other. So people who are older often, always, but often have problems with digital literacy, and this can affect their health because it's their ability to maintain health appointments, to book health appointments, um, interaction with the NHS, for example, but it also impacts their ability to maintain social connectivity, to find out when events are happening and where events are happening, for example. Then you have transport. The affordability of transport can be an issue, especially now during the cost of living crisis. Mobility is an issue. If people are, for example, wheelchair bound or they have reduced mobility, then that can be problematic. And then there's the reliability of transport. It has to be reliable, otherwise people simply won't use it because they don't trust it. There's ageism within the population. The cost of living crisis and poverty compound each other. And then we have long-term health conditions, which can be mental or physical health conditions. Older people can be and often are carers, and they're often unpaid carers. And isolation generally increases as we get older, unfortunately. Then the specific challenges that face older LGBT people. So we have heteronormativity, which is the assumption that opposite sex attraction is standard within society. And this can be a problem because it leads to treating everybody the same, which means treating everybody as they were cisgender, heterosexual, which can sometimes lead to problematic conversations and situations. Then we have that kind of idea of cisnormativity, which is around gender identity that affects transsexual and transgender people. And then sex normativity, which is the assumption that people aren't intersex. Discrimination, when people face discrimination and hostility, that can lead to a reduction in use of medical services or in-home services, whether that is via the NHS or via, for example, care homes or hospices. There's often reduced support from families of origin, which people tend to rely on once they get older. Um, and people will often rely on non-traditional sources of support, chosen families, for example. The problem here is there's little socio-legal recognition that can lead to issues when people are extremely unwell and their family of origin may step in, even if they're somewhat estranged, and that can be quite traumatic and problematic. Reduced social support as people age, especially for transgender adults whose social networks have the fewest family connections. And then there's the fact that older LGBT adults disproportionately live in urban centres, are single, live alone, and do not have children, all of which can compound and make older age more challenging. So at the end of every section, I'm going to summarize what I went through to go over it. So a healthy lifestyle is a social lifestyle, and health that's really important for our health, mental health, and physical health. Challenges in older age are compounded by challenges of belonging to the LGBTQI community. There can be some isolation from the community in older age because the community is often youth-centered. And we have Birmingham LGBT working with older adults in the community, and in continuity of financial support for different endeavours, groups, and support networks is really important. And that came out of the engagement session. So we're going to move on to aging and look at aging. So influences of lifestyle factors on aging. So lifestyle factors affect how we age, such as whether we do or do not take exercise, the quality of food we eat, the alcohol drink that we drink, smoking, drugs, pollution, where we live, and social connectedness are examples of lifestyle factors. Um, how can this affect LGBT plus people? So it's recognized that LGBT plus people often, not always, but often have poor lifestyle factors, especially around alcohol and smoking, and this can lead to development of poor health. And within the community is often based around, for example, bars and venues. So it can lead to that going on later in life than for the heterosexual community that often have other ways out of that and drop out of those kinds of meeting spaces. So there can be the kind of culture within the LGBT sphere can lead to certain lifestyle factors over other kind of choices. Now, this can affect the number of years lived in good health, which is really important because as we go into older age, we want to maintain not only our mental faculties, but our physical health and our ability to do things. Fortunately, our bodies are extremely adaptive, and research has shown that exercising just once a week can improve basically all health parameters. And strength training, for example, improve protein intake can help reduce frailty, which leads to a reduction in falls. So though we may have or have had problematic lifestyle factors, these things can still be addressed in older age. Then we have ageism, which is the unfair treatment based on age. This is based on stereotypes, prejudice, and discrimination, as you can see. But this can really affect the health and well-being. The way people treat us really affects the way we think about ourselves and the way we interact with society, and the kind of interactions that we expect from society. There's a couple of stereotypes here to demonstrate what can be thought of older people within society. And this is something that we really need to work against for all older people, basically, because as we get older, only have more kind of knowledge and experience that we can use. And I wanted to highlight again intersectionality here and how different identities and marginal identities can compound with ageism. And then we have LGBT plus isolation and ageism. So loneliness generally increases with age of the population. LGBT plus people are often childless. They may face stigma from family members, and there's a lower chance within this population of having a life partner or significant other from their cis in comparison to their cishet peers, so cisgender heterosexual. In addition to that, there's the fear of the isolation. There's also worries of health issues, especially dementia. So with dementia, lifestyle factors are estimated to be responsible for about approximately 40% of the risk of developing dementia. Where dementia is a broad category, there are about 200 types of dementia, of which four are most common. LGBT people have higher risk factors for dementia. And if anybody wants to know more about this, at 2 p.m., as Bradley said earlier, there's a session looking specifically at this topic. Then we have minority stress, which is a theory that basically says that the unique stresses that are related to having a marginalized sexual or gender identity will lead to kind of discrimination and victimization. And then people may experience kind of identity concealment, expectations of rejection, and internalized stigma. And these are things that could lead to a heightened probability of poor physical or mental health. How are we doing for time? 24. There's a lot of work happening in this area. So these are just a few links here. A couple of these are academic articles. One is produced by the NHS, and another one I believe is Age UK. So there is a lot of work happening in this area. So things are hopefully improving, and hopefully that is seen. And if anybody on the call is doing work in this area, then please do put it into the chat so that we can learn from each other. So this slide is basically came from the engagement group session that we did. These were suggestions from that engagement session on how to help people age better. So we have improved funding for statutory services and community groups. regular and reliable transport services with accessible timetables in a written format. So that's nodding to that kind of digital literacy issue. Ability to speak face to face with healthcare providers was seen as really important. The provision of healthcare information in written form, again, digital literacy, digital access. Create more opportunities for social activities, but not in big groups, apparently. Birmingham LGBT or community groups to provide more service for older people that are well promoted and resourced, and we've seen that that is happening. And then discussion of social isolation, some of the ways that people can address this prior to retirement, so via a retirement pack, for example. And as you can see, a lot of these issues, a lot of these suggestions, sorry, are all orientated around the ability to be social, to have social networks, to make friends and be with people. So it's obviously seen as quite important, or at least within that engagement group. So in summary for this section, aging is not linear and health can be improved. So even if you've had, for example, poor lifestyle factors when you were younger, as many of us have, exercise and strength training and eating well can still change the body because it's such an adaptable thing. Ageism and LGBT identities compound one another, but there are inclusive frameworks that are being developed to address this. Intersectionality, other marginalized identities impact our experience of aging. Then there's breaking down of kind of heteronormative cultures, which creates acceptance and visibility of LGBT populations. And then the engagement participants from demonstrated ideas that were focused on social interactions. And as I said, please put anything you're doing in this space in the chat so that we can all learn from each other in this on this topic. So we're going to look at interactions with healthcare next. So gonna drop back into history briefly to start with, and acknowledge there was extreme prejudice and discrimination against gay men in the 1980s due to HIV and AIDS. And this led to discrimination against LGBT people generally, which at least some sources say led to Section 28 being put in force. And this extreme kind of homophobia was part of public conversations in the press and in political arenas, and it really set the tone for older adults' interactions with institutions and health and social care organizations because it creates an expectancy of what they would receive and the treatment they would receive based upon experiences during the 80s and during the 90s. This is kind of demonstrated here, traumatized by healthcare interactions from their youth. And there was also moralizing of this kind of anti-gay AIDS and anti-gay leaflets circled by council organizations in the 1980s. So it was really in many, many different spaces. And this is some of the kind of information and knowledge that the older adults in the LGBT plus community now will have experienced. Research on older LGBT adults shows that this kind of lifetime experience of discrimination leads to a higher instance of serious illnesses such as cancer and cardiovascular and respiratory diseases. Increased engagement in high risk behavior. So here we're talking about sorry, tobacco consumption and use of drugs. And they have had, and may continue to have in some instances, poor experiences of accessing healthcare services, which all leads also to a higher incidence of mental health issues. And then just nodding to the minority stress theory, which has done a lot of kind of work here in this space of understanding how these things link together. Um, Fear of discrimination can lead to reduced access to healthcare. People often access healthcare later, and when they do access it, this can lead to late diagnoses, which can then lead to further complications and issues, which is a really significant problem. There's a lack of understanding in healthcare around people within this population. And this survey here, 108,000 respondents, this was an LGBT survey, so it wasn't just older adults. It was a broader survey, but it shows that amongst cis LGBT plus people, LGBT people, 46% didn't disclose their sexual orientation to healthcare, and 8% said that disclosing sexual orientation had a negative effect. And then the figures are worse for people who are trans. 21% said the specific needs were ignored or not taken into account. 18% said they were subject to inappropriate curiosity. and 18% also said they avoided treatment for fear of discrimination or intolerant reactions. And then intersex people who are intersex will likely experience some of the same issues, especially around, for example, inappropriate curiosity and over medicalization. And this all leads to different kinds of interactions with the healthcare system. And these interactions can sometimes be problematic because healthcare staff themselves feel they don't have sufficient training to have these conversations. They don't have that vocabulary, that confidence, and they feel that they need more work in this space. And LGBT plus people working for or using the health system are still reporting issues even now, despite, for example, different training standards and protections being put in place. Is one example here, which is the core training standards for sexual orientation, which was published in 2006. However, again, there is work happening in this space. So this is a report from King's College London. It's based on some academic work, and they recommended, for example, positive verbal and body language is really important to put people at ease. Sexual orientation and gender questions should only be asked, and they should be relevant when they're relevant to the care, and that should be standardized across all of the systems, basically, so people aren't asked different questions at different times that don't seem to relate to the issue at hand. Remove the need to repeat such things as or sexual orientation or gender if people want them to, and that to be shared across organizations. And then this was praised by a spokesperson from Stonewall Institute as very positive. So again, work is happening in this area. So looking at care when you're elderly and LGBT plus, as we said before, or as I said before, there can often be a lack of family to take on responsibilities, which can be an issue. LGBT plus people felt that the care must be specific and accredited, respectful, safe, and also recognize those lives and histories that older adults actually live through and the kind of specific trauma that may have caused. There can be housing discrimination, which can be made worse by people having multiple marginalized identities. And for example, in care homes, there can be those kind of heteronormative cultures that I discussed earlier, and that leads to the assumption that there are no LGBT plus people, which is an invisibility for people who are LGBT plus that can lead to recloseting or detransitioning or their heterosexualization. And this can all be made worse by underconfident or inadequately trained staff, which I just mentioned. So that's obviously an area where work can be done in this space. Having said that, work is happening in this space. Mary Curie, which is a national organization, have been doing a lot of work in this space, for example. They have LGBT plus resources. They did a really good report that was funded by Superdrug. They've had a long-term kind of relationship with Superdrug. They did a Hiding Who I Am report, also Planning for Your Future. And then they have inclusivity documentation for the hospices, as do many other hospices in the city and in the country. I think they have a hospice down in Solihull as well. In summary, for this section, discrimination can lead to um, poor outcomes in healthcare settings. People who are LGBT plus are often at heightened risk of poor physical and mental health. They often fear discrimination from healthcare services. And this can be due to a lack of that understanding in healthcare where more training may be needed. However, work is happening in this space to kind of reverse these trends or continue to reverse these trends. Okay, so I'm going to look at mental health now. So mental health issues for people in the community, especially older people, higher rates of common mental health disorders within the community are prevalent. Within the 55 plus age group, it's associated with more than twice the risk in comparison to heterosexual reference groups. And bisexual identity was also associated with a much higher risk of poor mental health. And people within the community are more likely to have attempted suicide than people within the heterosexual reference group. Um, Isolation is much higher. There's higher rates of living alone that can lead to poor mental health. There's concern about accessing healthcare services that can lead to not reaching out for help and support when needed. And that's down to fear of discrimination that can be happen in multiple settings. And this is partly due to that kind of chronic stress about internalizing stigma that leads to this poor mental health, poor well-being, and all of these things, as I've said before, lead to increased risks for dementia because social interaction, good positive social interaction, is a protective factor for dementia. The quality of your social networks really does benefit people, as does things like education, um, avoiding smoking, avoiding problematic alcohol use, diabetes, high blood pressure, overweight, exercise, and other things. So when you do these things and can do them with people, they protect you from risk of dementia. And it's recognized that more research is required in this area. In an engagement session with older adults that I mentioned earlier, there was an acknowledgement of hidden trauma within the older adult population, and they generally felt that the typical treatments that you can access for mental health were insufficient for their lived experience. Although they suffered significantly in the 80s and 90s, they feel that the city's character has changed enormously, and now that Birmingham is quite a welcoming city, a very gay-friendly city. And we'll look at a few quotes from that engagement session now. So here, for example, someone said it wasn't an easy time in the 80s and 90s. Another person said, our experiences when we were younger have impacted us a lot. The country was not as accepted in the 80s and 90s. If you could pass it straight, you did. This impacts relationships that you got into, including heterosexual ones, which adds more trauma. Um, Most of the participants acknowledged they'd been in a closet in the 80s and 90s. And one of the participants said that when they go into a hospice, they have kept quiet about their sexuality because they didn't want to upset their kids or immediate community. Someone else said that, but for those with a degree of homophobic trauma and family issues, the degree of therapy needed is not available. So people may isolate themselves more, and that's a toxic brew for older LGBT community. So you can see that there's a lot of specific issues that relate to older adults within the community due to their experiences of living through the 80s and 90s. Um, in summary, prejudice and stigma affect mental health. This is extremely problematic for older adults because of the levels of homophobia during the 80s and 90s. Um, People can face discrimination from multiple sources. So this is primarily about age and LGBT plus, but there's obviously race, ethnicity, disability, and other forms of discrimination that people can suffer from. This can lead to hesitancy in accessing health and care and other services, which can be extremely problematic when it comes to receiving a diagnosis, especially for something that's very serious. And then we have the idea of minority stresses that affect people of minority sexuality people and gender people that can lead to health inequalities, and they can be linked to poverty and physical and mental health. Okay, so final thoughts. So we've really talked about dual discrimination in this presentation and the outcomes it can have on physical and mental health, whilst acknowledging there are further minority marginalized identities that can compound that. Poor well-being and social connectedness can lead to loneliness and isolation, and this can actually be very, very problematic for physical and mental health. Good, strong social connections are extremely important for maintaining our health. It does actually impact us physically. Um, End of life preparation can be made more difficult. It's affected by stigma, isolation, risk of disclosure, and also isolation from kind of family members. And our engagement participants really wanted to see a continuity of funding for services to support them, greater control of priorities. We're really keen to see a kind of a formal strategy to guide work in this area. And these are all issues that are not due to intrinsic characteristics, but of the social structure of our society. And so these are all things that can be changed. Okay, so I'm going to open up to questions now.